Hello, welcome to the Dying to Know Day discussion and webinar. I apologise for starting a few minutes later than our planned start time. We have tried to set this up as a hybrid style event so that people can be together watching on site here at Cottesloe, as well as those of you tuning in online from wherever you are. So I do apologise for a couple of little minor technical issues, but hopefully everyone will be able to hear and see. And look, if you do miss any part of the webinar, it is being recorded and it will wind up on the Breast Cancer Care website and be available through the other charities that this event is collaborating with today. Before we launch into our webinar content, I'd like to acknowledge the traditional custodians of the lands that we're meeting on. I'm streaming here from Whadjuk Noongar country, and I invite you to take a moment to connect with the lands that you're on and to recognise and remember the elders of the past and the present. Because we do come together on sacred space, and whether that's virtual or physical, this topic about the end of life, it is a sensitive and important and sacred space that we're entering together. So if you need to reach out for any resources, either your own internal resources to calm and comfort yourself, or external resources with the people and places that are around you, I encourage you to do that. The structure of today is a series of guest speakers, and they're all really wonderful, heart-centred humans who have worked extensively in the space of palliative care and end of life and death education. If you have questions for our speakers, I encourage you to use the Q&A box. So on your screen across the top, you should have a little question mark bubble. And if you want to pop your questions in there, I will make sure that your speakers see them at the end of their presentation so that they can answer any questions that you might have. I will also let you know, those of you who are fully online, that there will be an online discussion group offered after this. So if you just feel like you don't have a question, but you would really like to debrief and discuss your situation or perspectives, then we'll send you a separate link for that. So our first speaker today is Julie Verley. Julie is a social worker with a master's in counselling, and she is the manager of psychosocial services for Solaris Cancer Care. Just going to mute Angie, looks like she's set up downstairs. So Julie's the manager of psychosocial services for Solaris Cancer Care, which is also here on site at the Cancer Wellness Centre. Julie's experience is vast, includes being a grief counsellor for Red Nose and Angel Hands, and she's also worked in palliative care settings, including Bethesda Hospital. Julie's going to talk to us today about advanced care planning. Over to you, Julie.
Thanks, Chandrika. Can you hear me clearly enough? Beautiful. And thank you, Chandrika, for initiating this, this webinar and for being brave enough to open up a space for people to be able to have these conversations about death and dying, and particularly at the end of life. I think it's something we all want to have, but there's often not a space where people can come to. So I think it's been a wonderful opportunity. Thank you. So I'm going to share my slides with you. See if it all works well. Can you all see that? Yep. Is that working? Beautiful. I can't see anyone else. I can only see you, Chandrika, so give me a quick heads up if something's going wrong. So the topic I'm going to talk about is advanced care planning. Advanced care planning it involves planning for your future healthcare. It enables you to make decisions now about the healthcare that you would like or not like to receive when you become seriously ill or you're unable to communicate your preferences. The WA Advanced Care Plan and Advanced Health Directive is probably one of the best in our country at the moment. It took a group of people over a good period of 2 years to put all this information together and reach out to the community and ask them what they wanted to create this particular document that you can see on your screen. So it's been a well-researched document, a lot of community and patient input to get to this particular point. And I think we should be very proud of what we have in WA. So to do your advanced care planning, it's a process and it takes a bit of time, which is why we tend to not rush it. We try and get people to take their time, talk about it, really explore their values and their beliefs that will influence the choices that they want to make about their future healthcare. So, you know, at Solaris, we offer a 3-week advanced care planning course where you come and we actually choices and your values and your beliefs, and we work through it. So if you've got somebody else that you can have that conversation with, that might be helpful as you're about to embark on this particular document. And ideally, we should all be doing one, and I'll get to that in a little bit later. So why do we want to have an advanced care plan? None of us know what's going to happen in the future and what challenges we may face. Some of us have a more clear idea of the fact that we're unwell or that we're chronically ill, but others may have an accident and equally need this document. So this document is going to allow you to speak to your doctor and your health professionals and conduct structured, meaningful conversations about what your wishes and preferences will be regarding the treatments that you may or may not want. It's going to be a person-centered form of care that allows you to have your personal preferences about your medical care and treatments upheld. The document also ensures that you receive the care that is consistent with your wishes. And I think that's really important because it starts to reduce the stress on the family when they're sitting in a situation where they're now having to make decisions about what treatment you may or may not want because you're unable to say anything. It puts a lot of tension and stress on family members, and you get a little bit of, sometimes there's even conflict between family members saying one thing and another, and that health professionals also struggle as to what to do. So it takes a lot of stress off everybody, and also gives you peace of mind to know that your wishes will be upheld once you've completed your document. So who might need an advanced care plan? Well, everyone. Ideally, you'll complete an advanced care plan when you're able to communicate and have legal capacity. But it's especially important perhaps if you know you have a chronic illness or you have other multiple medical conditions. For older people who are nearing the end of life, this is also a good time for them to start to think about making out an advanced care plan. If you know you've got a life-limiting condition, and also if you're at risk of dementia. So that's, if you know genetically that that's potentially something that might occur, then it's also a nice opportunity to start thinking about doing this while you still have an opportunity. So it is a process, and there's many steps to the process of completing your advanced care plan. So often doing it either in a group or with someone that you can trust, with your health professional, is a good idea, but starting just with looking at the document in itself is also a good place to start. Ideally, you want to start looking at, what are your values, what are your beliefs, really exploring that. And you can use value cards to kind of just get a sense of what are your core values so that you can use those to influence your choices of your future health treatment that you may or may not want. Other things to consider in the process is taking your past experiences of health into account. So really thinking about what experiences you've had in the past with healthcare professionals or even in hospitals. There's some experiences that you find you might have had that were really unpleasant, and you certainly don't want to have that again. So you would make a note of that in your care plan, saying that that's treatment you certainly don't want, or even a location that you don't want to go back to. And again, if your health professionals and your caregivers and loved ones know that, that's more likely to happen. Getting a good understanding of your current health is really important. So ask as many questions as you need to from your health professionals, get all the reports that you need, gather all the information that you can so that you've got a really good understanding. And that's about your body as well. So understand that if your body is particularly frail in certain areas, that will also influence your choice of wanting certain treatments. You know that if you were to have CPR and you've got a very frail chest bone, then it might impact on your decision to have or to not have CPR. So getting a really good understanding of your current health and your physical body is helpful in making these decisions. And then consider what preferences you want for your future health. So taking the past, the current into account, and then sort of thinking about what does your future health treatments look like that you may want to consent to or refuse. Another thing to think about is who would you like as your substitute decision maker? Now, we will discuss this a little bit more, but it's a good thing to start thinking about who that person is that you might want to advocate on your behalf when you can't speak for yourself. And then going on to have long and ongoing discussions with your loved ones, and then start writing up your advanced care directive. So that's a little bit of what the process might look like. This is a beautiful visual from Palliative Care WA that sort of takes all of what I've just said and puts it into a context of think, talk, share, and write. So Palliative Care WA and WA Health have amazing resources. So I encourage you to use those resources. So why chat? These are statistics that come from Palliative Care WA. 8 out of 10 people say it's important to think and talk about their preferences or care at the end of life, but sadly only 1 in 4 people have actually spoken to their family about their preferences, and only 6 people have spoken with their doctor about their preferences. So this is why this particular forum that Chandrika's put together is so important. It gives people a little bit more confidence perhaps to go out there and have these conversations with their loved one, because we all know it's important, we all want it, but none of us are finding the opportunity or the courage and the confidence to go ahead and have these conversations. So hopefully at the end of today, you've got a little bit more to take away from here and use that to open those discussions with your loved ones. So as part of the healthcare planning, we have an advanced care directive. So this is a document that is specifically about detailing your preferences. So it's a legal document where you're going to start writing in there what choices of treatment you do or don't want. And you're going to take the values that you started to look at and explore at the beginning, and you're going to allow that to start influencing what those preferences for your treatment will be. It is a legally binding document. So when you sign it, it has legal capacity. So you have to have legal capacity to complete it. And once signed, it becomes a legal document that your doctors or loved ones are not allowed to override. So I think it gives you confidence that your wishes will be adhered to. And I think that's really important, particularly when you're unwell. Am I rushing through this a bit too quickly, Chandrika? So, I mean, there's so much to cover in the advanced health directive, but I think the first part 1 of the advanced health directive is mainly just collecting all your personal information. Part 2 and 3 is around your wishes and your values. They don't have to be completed, that's optional. But in your document, the legal advanced health directive, part 4 and part 4.1 is not optional. You have to complete that, and you have to tick at least one option on that in that part of the document. It's probably the most difficult part of the document to complete. It's often what stops people finishing completing this document and uploading it, because it is pretty scary to actually have a look at some of those treatment choices that you have to tick. So currently, it lists a number of treatments. Just to give an example, some of it would be things like CPR, and you would have to say, A, I consent to this treatment in all circumstances. I consent to this treatment in the following circumstances, and you will list what those circumstances are. And C, I refuse consent to this treatment in all circumstances. Or you can even tick D now, which is I cannot decide at this time. And for those who really are struggling to know what treatments they might want to consent to or refuse, just tick I cannot decide at this time and get the document uploaded, at least with some of the decisions that you know you do want or don't want. And you can always come back to this document and update it and review it at any point. So sometimes if you're really struggling to decide whether you do or don't want treatment, then rather just tick that box, get it uploaded, come back to it, and keep thinking and talking about it. If you choose B, consent to this treatment in the following circumstances, try and be as clear about what those circumstances might be. Now, that's very difficult to know, because all of our health situations are different, and we there's no ways you're going to be able to cover every possible circumstance that might happen. And that's where your substitute decision maker is so important. Because if they know who you are, what your wishes are, they're going to be the voice that needs to be able to take an unusual situation and decide whether or not what treatment you would or wouldn't want. So obviously you can't cover every single circumstance that might happen, but to the best of your ability, put in there what you certainly know you may or may not want. Just to give an example of something would be, and I'm just using some clients that I've worked with in the past. So someone did tick that they didn't want artificial assisted ventilation, but they did consent to having it for a period of 48 hours, which was, they wanted enough time for all their family members to be able to travel to where they were. So this was in the event that they were going to be on artificial assisted ventilation, so that all the family members could come together and connect around this person. And then after 48 hours, they then wanted the treatment to be stopped. So that was important to them. They said that in the event that this should happen to them, they wanted all their family members to come together to have an opportunity to connect and to say goodbye. And then they wanted the treatment to stop. So that's just a brief example of the sort of circumstances you may or may not want to put into place. And for others who are unsure about CPR, they may say, well, I'm happy to consent to CPR for a period of 20 minutes, but following that, if there's no particular, not a guarantee, but any sort of idea that it's not going to work, or that it's not, there's going to be no positive outcome, then they said, then I would then want the treatment to stop. So this is where your past and current health is helpful in you sort of knowing what your body can endure, but also knowing that if that treatment was to happen and you were to not be able to talk and your quality of life was to be limited to things that are important to you, then you would want that treatment to stop at some point. So it's not easy to make these choices, and that's why coming together as a group and talking about it and having a deeper understanding of what that might look like is worth it. And that's the process. So take your time, be gentle with yourself as you're having these sort of conversations and chats with family members, because they're difficult decisions to be talking about, and it's scary. Everyone gets a little frightened about these conversations. Another part of the document that's really important is your substitute decision maker. So again, when you're having conversations with family members and you're chatting about what you do and what you don't want, start to think about who the person is that you might want to put in your document as your substitute decision maker. So this is the person that will be, they will sign, their name will be in your document, and they will sign as a witness as well. They agreed to be your substitute decision maker. So please have the conversation with the person so that they're aware that you have chosen them to be your substitute decision maker. Let it be someone who you have a really good relationship with, that you know that you can trust, that in the event that it gets to this point that they need to advocate for you, that they will have the confidence and courage to do that. Even if it's not what they agree, they may still be able to uphold your wishes. It doesn't always have to be a partner or an adult child. It can sometimes be a good friend that's perhaps easier for them to make these decisions rather than into your immediate family. They do need to be 18 years old at least and older, someone you can trust, someone who will listen and respect your values and your preferences. And again, as I said, someone who's comfortable making these decisions because it's a very difficult moment when suddenly they've been asked to tell them, the healthcare team saying, okay, tell us what this person would like, and they're all sort of quite stressed and distressed, and so the person needs to be able to know that they have that ability to step up and make those decisions for you. Just a quick look at this visual of the hierarchy of decision makers. So your Advanced Health Directive is right at the top of all the basically everybody who can make a decision on your behalf in the event that you can't talk for yourself. So you can see how important this document is. It's right at the top of this hierarchy. So if you don't have an Advanced Health Directive, that decision making will then fall on your enduring guardian. If you don't have an enduring guardian, it will fall on your guardian. If you don't have a guardian, it will fall on your spouse or de facto. Then your adult son or daughter, parent, sibling, primary unpaid caregiver, and then other person who you have a good relationship with. So this just gives you a little bit of idea of how powerful it is to have this advanced health directive, but it takes the pressure of other family members to make those decisions when you can't talk for yourself. There's so many beautiful resources out there at the moment that can help you. So we looked at the value cards, we've looked at the actual advanced care plan, the advanced health directive, but these are cards that are called Dying to Talk cards, also known as What Matters Most cards. Again, I encourage you to use all these cards to help you explore what your wishes are for end of life care in particular. It's also lovely cards to play with and get a sense of, what's important, what's less important, what's not important at all. It can open up conversations with family members and make things a little bit easier to sort of start the conversation with. So use these resources. If you've got them, they're easy to access online, and they're all for free. So again, it's nice to have access to that. And then start to write. So we've very quickly gone through why is an advanced care plan important, and actually the detail of those decisions are put into your health directive. But starting the writing is where I find a lot of people struggle. Like they talk about it, they explore it, but they still struggle to actually start writing. So I encourage you to just start writing. And as I said, even put I don't know at this point in some of your choices, get it uploaded, share it and discuss it with your guardian, your family, your friends, your caregivers. Share copies with your GP and other health professionals. There's a small little advanced health directive alert card that comes in the pack when you order it. Pop that into your wallet. So in the event that something happens and you're not at home or no one's with you, the paramedics or the hospital staff will often look in your wallet or your purse to see if there's a copy. There's also a beautiful little fridge magnet that St. John offers for an emergency medical information booklet. And in there, you can also put that you've got an advanced health directive, where it's placed, and where you've got a copy and who's got a copy of your advanced health directive. And then upload, if you can, your advanced health directive to your My Health records, so that if you do go into hospital, the health professionals can often see your document up there and know what you want as well, and contact your substitute decision maker. Review this document regularly. Things change in life. Your conditions change, your marital status change, your health conditions change. So reviewing it regularly, I suggest to people every 2 years, but if your health changes more quickly, then perhaps more regularly. It is a really wonderful thing to know that it's a fluid document. So once you've done the original document, it's not a given that is how it has to be. You can actually update it as often as you want to. You can do it online. So you can do a PDF online and upload it. Alternatively, you can actually order the actual physical document itself and complete it in writing. Then still have to upload it onto a PDF and still put it onto your My Health record. So it does require a little bit of technology, but hopefully the WA Health has got a beautiful guide on how to do that step by step. So you should hopefully not have to struggle too much with that. That's really the end of me. I think I've run through that pretty quickly. Is there any sort of questions or things that anybody wants to know?
Well, I'm not seeing anything in the Q&A box at this point. So participants, because you're in a webinar, in case it's not clear to you, you can't unmute yourselves to ask out loud at this point, but you can type your questions in. So I had lots of thoughts during that, Julie, and yeah, it's a big topic, isn't it? And quite big decisions to make. So I can see that this requires a bit of time, gentleness, as you said, and patience to work through. So I really appreciate the info that you've shared, and it's going to kind of percolate in my mind and heart, I know. So thank you so much, Julie from Solaris Cancer Care. Our next speaker this morning is Claire Doyle. Claire is a palliative care nurse practitioner, now working at Armidale and Kalamunda hospitals. She has vast experience, has worked across all the main hospitals in WA and also in the community in programs including advanced dementia services and hospice work. So over to you, Claire.
Hi, welcome to those online and in person. Thank you, Chandrika, for the intro and the acknowledgement to country. So it's my role today to go some way, not completely, to maybe demystify some of the ideas around palliative care and make it a bit more approachable for people as they move forward in their journeys.
Perfect.
Okay.
Carry on.
Oh, where we go? Here we go. That's it. So yeah, I aim to bring palliative care more comfortably into your vocabulary and leave you with an open mind to the benefit of the service. So I'm opening with some of the comments I've had in the last week when speaking with patients and families. These comments are driven by the fear of preconceived ideas, as I say, hearsay, experiences of others, friends, newspapers, television and films. The perception of palliative care's close proximity to one's death or the mere mention of it bringing one's death closer have many running for the hills. But let's take a closer look at the origins of the modern palliative care movement. So the ethos of care and compassion is centuries old. The modern palliative care movement began with Dame Cicely Saunders, who's pictured here with one of her patients. She was widely regarded as the founder of the hospice movement, which had its origins in the UK in the 1960s. She had degrees in nursing, social work and medicine and was truly a holistic practitioner. She introduced the idea of total pain, which has recognised the physical, emotional, social and spiritual dimensions of distress which could impact pain. And Saunders opened St Christopher's Hospice in London in 1967. Professor Balfour Mount, a surgical oncologist, was the first to coin the phrase palliative care, distinguishing it from hospice care, with hospice falling under the umbrella of palliative care, and with palliative care providing benefit from the time of diagnosis of a serious illness and used concurrently with curative or life-prolonging treatments. He founded palliative care in the Royal Victoria Hospital, and the first of its kind in Canada. So as a specialty, palliative care was only recognised in the UK in 1987 and by the World Health Organization in the 1990s. The word palliative actually comes from the word palliere, to cloak, and we'll actually look a little later as to why this is so important, and it's certainly not specific to end of life. So in defining palliative care, we see it as an individualised approach that responds to the diverse needs of those requiring relief from pain and other symptoms of their serious illness. Palliative care is an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illnesses through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other symptoms, which may be physical, psychosocial and spiritual. It can help you cope with the side effects of medical treatments and can walk alongside other treatments. And the availability of palliative care does not depend on whether your condition can be cured. Some of the other concepts here where we consider life as regards dying as a normal process and it neither hastening nor postponing death. So those with life-limiting illnesses, who are they? So we recognise all, and the fact that no one is forgotten or excluded from this approach. We recognise that there are those with intellectual disabilities who may not be able to communicate their needs, regardless of the environment that they come from. So whether they're metropolitan or country, whether they live alone, whether they have a voice through other people, regardless of their faith. It's not age dependent and it is not disease dependent. We do highlight those, though, that recognising minority groups who may actually be marginalised away from understanding palliative care. And that may be the Aboriginal, Torres Strait Islander peoples, cultural and linguistically diverse, especially new migrants into our environments, lesbian, gay, bisexual, transgender and intersex people that may feel marginalised by this approach, living with disability, and that's including dementia now, one of our primary causes of death, experiencing homelessness, those in long-term institutional care and including those in prisons, the ageing and frail. So who is palliative care actually for, and what do we call serious illnesses? We see from the statistics on the right here that they are clearly from the World Health Organization, and their leading cause of death in that environment was from cardiovascular disease. Now across Australia, the leading cause of death in women and the second leading cause of death in men is actually dementia. We are involved regardless whether people can communicate their needs or whether they're speaking through other people. So for any cancer, heart disease, lung disease such as COPD, any kidney disease, and there is a ream of other diseases that really are never excluded from the involvement of a palliative care approach. So who are the people that are actually involved in your team? The size of the team is often dependent on the environment. There may be one team member in remote areas. There may be all of these people involved in a hospital environment, but all are focused on your holistic care. A majority of the symptoms experienced through the trajectory of a serious illness include disturbances to sleep, pain, breathing, nausea or vomiting, bowel interventions and appetite deterioration. Actually, appetite can worsen with some treatments, and also fatigue, which unfortunately we have no magic pill for. On the right-hand side is a diagram of the involvement of palliative care. It is rather a crude way of looking at people's disease, but it just enables me to highlight that palliative care is involved from active disease through a time where there are actually minimal treatments that are used for patients, through to the fact that they may not be having any treatments and purely a comfort care and symptom management approach. And there are a variety of environments that this can occur in. So what are some of the myths that people think about when they consider palliative care? So the fact that palliative care makes death occur sooner. It actually helps improve comfort and quality of life from diagnosis to death. It doesn't make it occur sooner. Palliative care is only for people dying from cancer, and you'll have seen from the list of diagnoses that I provided earlier that there is definitely not a cancer link to palliative care. It's all life-limiting conditions. People in palliative care who stop eating die of starvation. What we find through deterioration and advanced illness, often people don't experience hunger or thirst as healthy people do. And we often are not capable, alert enough to actually take diet and fluids. And the body does a good job in winding back naturally itself. They actually die from their illness, which has resulted in this deterioration, not starvation. Palliative care is only provided in a hospital, and I've got a couple of slides that highlight actually where palliative care can be received, but it's actually multiple locations in your home, in your facilities, in hospices and in hospitals. The protection of children from the dying is often where one can provide a time of preparation, as we all need, and often discussing openly people's deterioration, I'm sure will come up in the next speaker's slides. So pain is part of dying, and very definitely that's not the case. Some people don't experience any pain throughout their disease at all. Taking pain medications in palliative care leads to addiction, and the aim of pain medication in advanced disease is to manage a symptom and not as a result causing addiction. Morphine makes death happen faster. Morphine or medications similar to it is used to help keep patients comfortable, and in proper doses, morphine does not make death occur sooner. Holding off pain relief to save it for later. Please encourage everyone to take their pain medication when they need it, so it actually makes life and their quality of life better. Palliative care means the patients and the doctors are given up and there is no hope. There is always hope, even through deterioration, through changes of perception. It may not be that we're curing a disease, but a life can continue to be fully lived through that time. And it's a time of changing goals. If my family member or friend doesn't die at home, I'm letting them down. So we find that promises to keep people at home are often made in a time where people are well. It doesn't actually consider what that deterioration may look like. And if symptoms are difficult to manage, sometimes home is not the right place. You are not letting them down if you continue to support them. These are enablers of quality palliative care, where it's highlighted that we initiate palliative care timely and as early as we possibly can, that we appropriately communicate information about the provision of care and the disease. We've already spoken about advanced care planning, that we understand that there are underserved populations to monitor for, and that we support community awareness and understanding of palliative care, which is actually what we're doing today. So palliative care availability. So within our hospitals, there are north, east, south availability at all of the major hospitals, providing consult and outpatient services in a majority of those. And also private hospitals provide palliative care teams at St John of God and Hollywood. The palliative care units or hospices. In the north, there's private with Glengarry and Bethesda having public and private beds. In the east, Kalamunda is a palliative care unit and also has a day hospice environment from Monday to Wednesday, where people are supported and communicate openly about deterioration and find great support between each other. And in the south, Maddock Community Hospice, providing patient beds as well, and also the day hospice service. Within the community, there's Silver Chain Community Specialist Palliative Care Service, which can be referred and visits the home directly. With MPACS, the Metro Palliative Care Service supports those in residential aged care, providing staff members with support through changing conditions of the patients that live under their care, as do the residential care line. Country services provide local palliative care teams in each region. They have visiting consultants, and some actually live in the regions. And there's also telehealth services through PalCats as well, which provide links both to the hospitals and is now starting in people's homes as well. Referrals are obtained from the lead medical team, such as oncology, neurologists, GPs, to outpatient and community services. Admission to hospital can refer from the teams that are caring for the patient to the consult services, who can link in with the patients and families within the hospital itself. And admission to hospice and palliative care units for symptom management and end-of-life care is via GPs, the community and hospital services. So what are we focusing on? The ability to maintain life, modifications to assist continued engagement, to add new activities to replace those lost, prevent isolation, a common experience contributing to the maintenance of self-worth. Participation in activities of daily life, purposeful and meaningful. Patients having choices that give them a sense of control, their identity and a competence in the care that's provided. Engaging in tasks and activities such as writing letters, recording favourite recipes within a social context, feeling productive, strengthening social relationships and memory making. Important climb factor is engaging in and facilitating connection to meaning and purpose, enhancing spiritual well-being, quality of life and coping. Counteracting hopelessness, helplessness, and a feeling of uselessness. Identify meaningful occupations to engage in, teach coping strategies, and allow continued participation in their lives. Provided some reputable information that can assist in providing more information about palliative care. There's literature, but there's also the Palliative Care WA helpline as well. And there are often disease-specific links that will provide additional information related to your specific disease. And within the care search, so you can just Google care search, there is community information as well. So I'll finish with two of the quotes going back to the people that actually started the modern palliative care environment. So from Dame Cicely Saunders, you matter because you are you. You matter to the last moment of your life, and we will do all we can not to help you die peacefully, not only to help you die peacefully, but also to help you live until you die. And from Balfour Mount, what was surprised me is how little palliative care is about death. The death part is almost irrelevant. Our focus isn't on dying. Our focus is on the quality of living. So thank you for listening to me today. I hope that this has provided you with the courage to engage with palliative care, maybe redressed some of the myths that are now more aware of available services to link with. Keep communicating to explore your options and express what matters to you most. And if you have further questions, please reach out. And just keep dancing.
Thank you so much, Claire. Yes, just keep dancing indeed. I love a bit of Snoopy wisdom, and thank you so much for sharing your fantastic wisdom and experience, Claire. That was really thorough, and I love the bit of history and philosophy there as well that helps us, make that discernment that maybe takes down some of the fear that people have around palliative care. So thank you so much for your time and expertise. I'm going to hand over to our next speaker, which is the lovely Shelly Skinner. Shelly's the founder and the CEO of Lionheart Camp for Kids and a senior social worker at Perth Children's Hospital. She is award-winning and highly recognised as a leader in this space for her psychosocial expertise in the areas of dying, death, grief and loss. I think that's probably enough. You can tell us more, Shelly. Over to you.
Thank you so much. Thank you for having me come along and for being able to bring the voice of children into this space. And I did really want to start by thanking everyone in the audience. Thank you for your dedication and your care and your desire to help others. Without you and who you are and what you uniquely bring, the experience of many who are suffering illness or journeying towards the end of their life would be significantly diminished. We know that every living thing will die, every person, every animal, every plant, and yet in 2024, as a society, we're still yet to get overly comfortable with that. And so for those of us who are interested in this space or supporting people in this space or work in this space, what a privilege it is for us to walk alongside people as they live out their lives with the quality of life that they want and as much dignity and integrity and love and kindness and compassion as possible. So thank you in whatever way you make that happen for the community. Working in a hospital and a health setting can be really tricky, and lots of health professionals say to me, there's someone in my team who has more experience in this, or there's someone in my team who's been through this themselves, and they're just better at supporting people. And I think we all have worries like this from time to time, a little bit of imposter syndrome. Who am I to help others? And I just wanted to reassure you that you may not be the person with the most experience or the person with the best academic knowledge, and you might not even have a lived experience of a loved one experiencing illness, receiving palliative care, or who's died. But what you do bring is you. And that is unique and that is important because you bring something that no one else brings. And so I really want to harness as a community and as individuals and humans how precious our time and our presence is. You bring your own story, you bring your humanity, and it's these stories, the exploration and sharing of our lives that offer richness, connection, meaning, understanding. Storytelling is such a superpower, and it's a privilege, especially through illness, end of life, and in memory. And at no point is that more true than when working with kids. Kids love a story, and they want to know the who's, the what's, the where's, the how's in every story as it pertains to them. So one of the best strategies we can use in connecting with children and having them involved in healthcare, in illness, in end-of-life discussions and in bereavement is through storytelling and communication. At Lionheart, we're super lucky because we get to meet hundreds and hundreds and hundreds of young people who are actively trying to understand grief and navigate grief and work out how it integrates into their lives. Unfortunately, they've learned younger than most that all living things will die and what the impact of that death is in your life. My mum died when I was 26, and sometimes that feels like a million years ago. And sometimes it feels like yesterday. And I think for kids, and I can tell you that, I can use the words and I can give you all the theories and all the reasons. But for children, they don't know that. They just know that they feel angry, or they can't sleep, or they have a headache, or everyone around them is very sad, or there's not people around, or there's too many people around. So I think the art of communication, as Julie talked about before, looking at communication and what's happening in your family, I think is through story is a real power for us. For children and young people, when they're experiencing grief, they're trying to work out who they are in the world without their important person, and a really important piece of their life puzzle. They're observing their world to work out what to say, how to behave, and how they're supposed to feel about it. It's how we model and how we support and communicate children and young people that will determine the toolkit that they build, that they have to draw from. Young people tell us all the time that they want opportunities to talk and share stories and ask questions. They're seeking knowledge. They want a frame of reference, and looking for role models to navigate these uncharted waters. So in saying that, kids are way better at grief than us adults. They have this excellent ability to dip in and out of their grief. They're kind of a perfect demonstration of the dual process model that we like to work to. Children will be able to be focused on their grief, ask questions about their grief, be distressed in their grief in one moment, and then in the blink of an eye say, can I go play with my friends? Or what are we having for dinner? Which can be really unsettling for parents, because they think, did they not understand what I just said? Are they not sure what's going on? Do they not understand the gravity of the situation? But this is actually the power and the skill that kids have in being able to attend to their grief in a moment and then step away in a moment. Us adults, on the other hand, we tend to experience grief for longer, not necessarily more intensely, but definitely for longer. And we kind of like to marinate in our grief. We kind of get in a grief boat and we paddle it out to sea, and we sit around in it and we get really comfortable, and we put a grief blanket on for a couple of extra layers, and we really own our grief. Whereas children, they'll kind of jump in their grief boat, have a look around, see who's around, jump out and have a swim, then get back in their boat and maybe have a fish from the side of the boat and explore and tell stories and ask questions. And then they jump back out again and have another swim. So their approach to grief is actually incredibly healthy. Similarly, young people are actually very good and much better than adults at talking about death and dying and grief. As adults, we've learnt to get very awkward for the most part. If you're good at this, like, hats off to you, because sometimes I still get a bit awkward about it. But young people are just not awkward about it. They're surprisingly keen to ask questions and explore. And I guess for them, it's just another thing that's happened in their life. So it's something else to talk about. They talk about all the things in their life. They talk about school and their grandparents and their friends. So if somebody was to die, for them, naturally, they talk about it. So Professor Lauren Breen at Curtin Uni co-authored a research paper with us at Lionheart, looking at what children want to know about death and dying and what questions they have. So it's come from an activity we run at Lionheart called our anonymous question box. And it works on the assumption that every child who comes to our program will have a question that they haven't asked an adult in their life for whatever reason. And what we say is, over the course of the 2 days, you can write your question and we put in the anonymous question box. And on the second day, we have a doctor, a real doctor, come to camp, usually a doctor from Perth Children's or a GP or sometimes Silver Chain will come, and we'll sit in a group together and we'll answer all the questions. Their questions are amazing. So we collected questions from 10 programs. So about just over 200 questions, I think. And it was broken down into 5 themes. And those themes were causes and processes of death, managing grief, human intervention, the meaning of life and death, and what happens after death. So kids asked the best questions. Some of the questions were, how does the body actually die? Does it hurt when you die? If my dad dies of cancer, does that mean I'll die of cancer as well? How do I know when I'm dying? Why do people kill themselves? So really good causes and processes questions. In terms of managing grief, they wanted to know, why do I feel happy and sad at the same time? Why can't I sleep? How can you handle big feelings? And how do I come across as normal to other people? For human intervention, really interested in the nitty-gritty. Does everyone who goes to hospital die? How can I protect my family from dying? Why don't they always try to resuscitate people? Meaning of life. What's the point of living if you're just going to die? Why do some people get sick and some people get better, and some people get sick and they don't get better? And then after death, what do you do when you die? Where do you go when you die? Can people see you, or can you see people when you're dead? What is heaven? And can I still talk to my important person? So they have lots of really good questions. And the challenge is in the how do we answer them? Because as adults, and I am so absolutely guilty of this, one of my children will ask me a question and I will give them a 3-paragraph answer. That's not what they're after. They want to know, when someone dies, can they feel pain? And I can go into this whole biological answer and response, but my kids want to know, no, once your body dies, so you don't breathe, you don't have a heartbeat, you can't feel anything. And then I would say to them, do you have any more questions about that? And so if they do have a follow-up question, they can ask me my follow-up question. But if they don't have a question and I've satisfied their questions for now, they'll go off and play and then come back and ask me a question later. So I think really developmentally appropriate answers and short answers are really, and clear answers are really helpful. As adults, and in particular parents, aunts, uncles, grandparents, teachers even, we just really want to protect kids and young people from trauma and grief and tragedy in their life. And unfortunately, grief is one of those things in life that we just can't protect kids from. So just like us, they need to go through their grief. They can't go over it and they can't go under it and they can't go around it. They have to go through it just like we do. And that's out of their control and it's out of our control. And that makes it extra hard because we are controlling beings. Like we really want to have control. And there's so many things in our lives that we do to keep that sense of control. And like Claire talked about before, palliative care and end of life can sometimes feel like you are in a situation where you don't have a lot of control. So just like for adults, for kids, we want to give them every opportunity that we can to have choice and control in situations where they can. So what's within our control is to provide the language and the skills and the connection and the choice and control that young people can have as they experience their grief. I know one of the biggest challenges for me working in hospitals and healthcare is that often you don't see children as much. Maybe they're at school or being cared for by a relative during our business hours. And often we don't see children until maybe the final days of life for an adult or their parent or their grandparent. And it feels like we can't be as effective or do the work that we think would benefit them. And it's really hard. But in that challenge and in that feeling for me, I always feel really reassured by the work of Professor Samar Aoun in the compassionate community space. So compassionate communities assures us that it is our role, all of us, whether we're parents, social workers, grandparents, teachers, nurses, neighbours, whoever, the whole community, to provide opportunities and space and modelling on how to navigate, manage and explore your grief in safe and healthy ways. So everyone is unique and we all grieve differently. And that's the same for members of the same family. So different members of the same family will all grieve differently as well. And so there's no ideal model and there's no ideal package and there's no ideal magic nugget of support you can offer. So what's good about that is that sometimes the best support comes from not the most experienced person or the most knowledgeable or even someone who's paid. Often it's something that the soccer coach tells a child on a Thursday evening, or something that an aunt shares in her experience, or sometimes even, and often most importantly, when a neighbour organises a meal train and some meal deliveries for a few weeks. These types of supports and these types of modelling and opportunities and layers of support are really important for children and for adults alike when looking at grief and grief support. So at Lionheart, we really want to support you in supporting children, your friends, your family, your community when they need it. Our Raw to Raw program provides one-to-one grief counselling with families, with teens, with children, and we also provide support through our Raw to Raw program for grandparents, aunts and uncles, schools and workplaces. It's not a counselling program, it's grief coaching. So we provide psychoeducation, we normalise the grief experience, and we really want to make sure that, you know, families who receive great care during their illness, great end-of-life care, but find themselves waking up in their house the day after their loved ones died, thinking, I don't have my person, and my support crew from the community, from the hospital or from Silver Chain and my GP, they're still out there. They can't come to my house, and I don't have my person, and I don't really know what to do with myself. I don't have my role. And that's where we want to step in and help families not feel alone in that moment and just walk alongside them for the first 2 years of acute grief. So our Raw to Raw program is currently available to all families. And then we also have our new families camps, our returning families camp, our drumbeat program, a little bit of music therapy, never hurt anyone, and also our Lionheart Lounge, which is our online services. I was thinking about some little tiny bits of tips and ideas that you could take away for talking with children about grief and death. And I think one of the biggest things kids tell us is that they hear everything. So we think that they don't hear us. And we might be talking in another room, or we might be covering our mouth on the phone and whispering. But kids tell us all the time that they can be 3 suburbs away underwater with their earphones in. And if you whisper something to the person next to you, they will hear something. It might not be exactly what you want them to hear, but they will definitely hear. But if you ask them to put their shoes on to get ready for school, they didn't hear a thing. So it's a really important opportunity for families to be able to give clear and honest information to kids in relevant chunks to make sure that they hear information that they need to hear from you. So we hear this a lot in the space of suicide or voluntary assisted dying. Parents and grandparents and family will say, we don't want to use the word suicide, or we don't want to talk about voluntary assisted dying. And we say, that's absolutely fine, but you need to work out what your narrative is as a family. What does it mean to your family? Because if they don't hear the word suicide from you, they might hear it in the schoolyard or hear it from someone else who's going to give their own version, and probably not the version you want, and give meaning and give a meaning. So they'll give a different meaning to these tricky adult societal concepts that you are trying to protect your child through. So I would say one of the things kids say is, please try and be as honest as possible with us, just clear, not too complicated, and that they're definitely here for the conversation. And if you have any questions at any point, you're very welcome to contact Lionheart either through our website or online, through Facebook or Insta, all the normal platforms. We're always here to answer any questions, and our services are free to families.
Amazing, Shelley. And really, I'm so happy to see the work that you do through Lionheart. And that was a great presentation with some great takeaways. And you've also reminded me that that is something I'll do with all of our speakers today. When we send out the recording, we'll send you a link to their websites so that you can find them and find out more about the things that they're offering and what they're up to. So thanks again, Shelley from Lionheart Camp for Kids. And next speaker is Satyam Brown. Satyam is an accredited mental health social worker with a master's in counselling. He's worked across psycho-oncology and palliative care social work services and also education, including for the Cancer Council of WA, Cancer Support WA, Bethesda's Metropolitan Palliative Care Service. He's been a lecturer for postgraduate students at Edith Cowan University, and is currently in private practice where he supports people with trauma, chronic and life-limiting illnesses. In 2023, he began passing his skills to the wider community by offering a 55-hour end-of-life doula training. So over to you, Satyam.
Thank you so much, Chandrika. Thanks to all the other speakers as well. Shelley, I love your passion. That was awesome. something just to add on what Shelly was talking about, because I work with so many families in the preparation from diagnosis and walk alongside them all the way to end of life and bereavement. And you know, when you have children, you often wonder, should I disrupt their lives by telling them about what's happening, that I've been diagnosed with an illness or that I'm approaching end of life? And with all the work I've done with kids over decades, the same two things come up. So if someone does it, so if I've counseled children, either adult or younger, after a parent has died, and that parent hasn't told them, there's two guaranteed responses that they always discuss. One is they get angry that that people made the assumption that they wouldn't be able to cope. And the other one is that they get really upset that they weren't able to make informed choices because they weren't told about what's happening. And that even goes with young children as well. So things like I wouldn't have, you know, I would have behaved differently, or I would have made different choices about going out or doing things rather than spending time with mum or dad. If we don't tell the children, they don't have choice. And that really complicates their bereavement as well. I thought I'd just chuck that in there as well. So I'm going to talk about basically all of our roles as death educators, the risks of not being death literate. And so a lot of my roles, I mean, hearing Chandrika list all the things I've done in palliative care made me fatigued just listening to it. But it's a wonderfully fabulous field to work in. And you learn so much about life by working with people at the end of life. And one of the things that hasn't really been covered so far, so I thought I'd just quickly throw this in, because I've had so many conversations with people educating them about end of life and palliative care, is I think it's a really good idea to be aware of the kind of medical jargon around the 5 phases of palliative care. So if I could just take a couple of minutes to give you my little spiel. So there are 5 phases in palliative care, and the first one is stable. So stable doesn't mean that you're no longer palliative. These are the 5 phases of palliative care. Stable means that all your symptoms are being managed well. And they're physical symptoms, but they're also psychosocial symptoms. So whether that's, you know, your anxiety is through the roof, or there's relationship issues, or anything really, housing issues, accommodation, anything like that, financial issues, anything. So stable is when all of these things are being met. The medication, the amount of medication, the level of support are meeting your needs. And then we go from stable to unstable. Unstable means the opposite of that. So typically something new's popped up. It might be a shift in your ability to cope physically, psychologically, emotionally, whatever. And then what unstable means is we need to adjust the interventions that we're doing. That might be a temporary stay in a hospital, or even a hospice for symptom management to get the medications correct so that you can go back home. So we bounce between stable and unstable all the way through the first 4 palliative care stages or phases, or pretty much the first 3 actually. But we do in life anyway. You might be traveling along well, and then you get the flu, you need to go to the doctor, take some meds, take time off work, whatever. You rest, you recover, and you come back to here. So we bounce through these 2 things. And then we have deteriorating. So in the deterioration phase, this basically speaks to the activities of daily living, the ADLs. So, you know, the things that most of us take for granted, the ability to dress ourselves, feed ourselves, bathe ourselves, mobilize on our own, and things like that. Deterioration is when we need additional support or supports. So that might be like, all of a sudden I need a walker, or all of a sudden I need a shower chair. And then typically the supports increase over time. People can become stable and kind of plateau out in the deterioration phase for a period. So it's not, and the length of time in the deterioration phase varies all the time. So it can happen quickly, it can happen over years. And basically the supports increase until the person's receiving all of their care in bed. Like, because it's not only the medications that get, or things, medications that get rationalized. For example, you might have the palliative doctor go, there's not much point in you taking vitamin D at this phase, when you're having trouble taking the other medications that are more important for your comfort. So they take certain medications out, like a vitamin D or something that's more for long-term kind of impact. We also rationalize things like, look, whenever we try to give you a shower in the bathroom to get you up, it fatigues you so much that you spend the rest of the day sleeping and you're not awake to spend time connecting with family. So how about from now on we do bathing in the bed or something like that? So we rationalize the interventions. And then the fourth phase is the terminal phase. This is the active dying phase. You're unconscious and you're dying. So, and this can go, this can happen quickly. It can happen over a day or two or three. The longest I've ever seen it happen in my career is about 10 days, I think. And I've never really seen that before, but typically it can happen overnight or quickly or whatever. The person's unconscious, and obviously we still give them the medications, or the doctors and nurses will still give them the medications, and they do that subcutaneously. So when you reach the point where you're either too fatigued or you lost your ability to swallow safely, they have to change the medications from orally to subcutaneous. So it's not intravenous into the vein. Subcutaneous means under the skin. And then what happens is, typically if there's 3 or more medications that are required for comfort, then they will use a syringe driver. It's like a little mini computer about the size of a tissue box, but skinnier. And they put the 24-hour amount of medication into that syringe, and the computer will precisely inject that into the body subcutaneously over that 24-hour period. What's fantastic about this is that the medication is consistent. It minimizes human error. For example, when someone's having an end-of-life experience in an aged care facility, there might not be a heap of staff around at night, so there's no issues around whether medications are being delivered in a timely manner or anything like that. And then an hour or so before the syringe runs out, it beeps, and then the nurses make up the next round. And you can still add in, so someone's symptoms change with the syringe driver in, if what they can do is add additional medications in at the same time that syringe is being injected through the syringe driver. And then what will happen is the additional amount in that previous 24 hours that was required, they'll add that into the syringe for the next amount for the next 24 hours. So, and then finally, the 5th phase in palliative care is bereavement, because bereavement is a huge factor in how secure we feel as we're dying. So one of the things that a lot of us don't think about is, most of us would walk over broken glass barefoot to support our loved ones when they're suffering. But when it's you dying in bed, you're looking out across the bed to your loved ones who are suffering because you're dying. And if I had $1 for every mum that I heard say that they feel guilty for causing the suffering through their death, I'd probably be retired by now. But so what happens is, it's essential that everyone involved lets the person who's dying know that we're all going to look after each other. And that includes that the staff are letting the person who's dying know that we're going to continue this care in some way, either through community services or supports. And it's also essential that if it's you that's palliative or going through the dying experience, if you have specific concerns about a family member, like you might look at all of your kids or your partner or whoever else is in your life and go, I think these ones over here, will cope pretty well, but I'm quite worried about this person here. You need to communicate that to the staff or the support people so that they are aware of that and can add in extra supports as well. So that's my 5 phases of palliative care. I think it's really important to know that, because you'll hear medical staff talk about this and you'll have wonderfully strange ideas if we're not educated about that. So there's a real need for all of us to be educated and to be death literate, because a lot of the suffering that happens to a person who's dying is quite often caused by bad decisions and by people who have a lot of power to make those decisions. And when they're not involved in the planning, what happens is those decisions are based on things like, well, they're based on emotional decisions. They're based on hearsay. So an example might be, my neighbor's uncle's butcher was saying that when their mum had the syringe driver put in, that they died not long after. So those things kill people. Clearly, you're not putting that on my mum. And so a lot of hearsay happens, and a lot of people will make decisions based on that. But when you drill down, they realize they actually don't know at all. And so the more informed we are ahead of time, and when we have a heads up, and when I talk to people about, like, the typical dying process for someone with a condition like that, what it looks like, what the interventions are, the type of reactions that we all have as we're dying, then as they're going through the process of watching a loved one die or themselves dying, and they're seeing these things play out, then they can go, oh, I learned about this. Oh, I know about that. Oh, that makes sense. That's exactly what they said would happen. So it takes the fear and the anxiety out of the not knowing from occurring. Last thing we want to do is to make decisions out of fear. We want to make educated decisions based on science. And that's essential. But unfortunately, we live in a society that's largely death denying. We push death into the hospitals and into these kind of out of communities vision, and we all lose because of that. And one of the things I often tell parents who are dying, and I encourage everyone who's dying, is to share what that experience is like. One moment I'm totally cool with it. I'm like accepting of it. And the next moment I'm freaking out. I don't want to die. And I'm attacking loved ones around me, and I'm pushing love away when I want love to come near. And then next moment I'm okay again. So, this is really confusing for the people all around that person. But when they explain to them this kind of process about, I'm feeling like this and now I'm feeling like that and now I'm reacting this way and etc., then what happens is when your children and your partner's um, time to die arrives, their mind is going to go, I haven't done this before. I got no idea what I'm meant to do, what's going on. I'm scared shitless. So what will happen is they'll access their memory, and they'll go back to when you died or the death that they witnessed. And the more that you share about your process, the better. But the reason that we don't do that is because what you'll have is all your loved ones freaking out, and they'll be saying to each other, or they'll be thinking to themselves, I don't want to burden my loved one who's dying about what I'm going through, because they're the one that's dying. That seems selfish. And the person who's dying will go, I can see they're all suffering. I don't want to freak them out even more and burden them with what I'm going through. But we all know that in any relationship, if we don't share what we're going through, then what we do is plug in our imagination into the bits that we don't know. So if you say, for example, look at your partner and see that they're distressed and they're not telling you what's happening, then you plug in with your imagination what it must be, and then you're dealing not in fact. And the more that we share with each other what our process is like, on both sides of the bed sheets, the more that we know how to respond and what we need. And that's another important bit as well. Like, when I'm feeling like this and at the moment I need this, is essential, because what happens a lot is that we don't share these things, and people guess and make assumptions about what it is that you need. So just quickly as well, I just want to share some really quick things about the importance of deciding to play the role as a support person. So for decades, I was talking, I was finding myself repeating the same things over and over to family members. And then when I left that role after about 8 years, I couldn't just let that go. So I decided to start an end-of-life doula course for lay people and, for people that work in these fields, but also for people that don't, so that they're educated about what Julie was talking about with advanced health directives and advanced care planning, and all the things that Claire was talking about the kind of hospital setting and that, because we all have a role to play and play according to your strengths. So you don't have to do it all. You don't have to be the doctor. You don't have to be the nurse. If your best position is to be the friend, then be the friend. If you're, really good at, helping people when they're distressed, then play that role. You don't necessarily have to be there for all of that. You can be on call for stuff like that. And there's different areas where end-of-life care can occur, where we can, all those people in those areas can do that. So we have, you can die in the home, and we have services like Silver Chain that will manage the medication and stuff like that. But there's also home care services, and Silver Chain has their own as well, where they might be able to help with household stuff, cleaning, tidying up, etc., showering, being carers and stuff like that. We also have hospices. So hospices are obviously purpose-built for end-of-life care experiences, or for palliative care, sorry. And then we also have wards in hospitals where there's palliative specialists working in those wards. And then aged care facilities, believe it or not, are some of the best service providers of palliative care, because they're dealing with it non-stop. So they become very, very specialized in aged care. And when we used to go into the aged care facilities, we'd really talk to the people about, do you really want to take your mum out of this environment where she's been living for 5 years, it's her home, and put her into the emergency department where they specialize in recovery? And if any of you have ever been in an emergency department, or put it this way, if I asked you, what's your ideal environment that you imagine your death likely to occur? Most people will say a quiet environment surrounded by my loved ones. Well, ED is neither of those things. If you got a maximum of probably 2 people that's allowed around you, and if it happens to have COVID there, then no one. And it's certainly not a quiet environment either. So we have to make hard decisions sometimes. Like if we see that someone's getting very close towards the end, and if we're not prepared, you're going to panic and you're going to call an ambulance, and they're going to end up in ED, and the chances are very high that they'll have a death in ED. So sometimes one of the hardest things when we're supporting a loved one, or even for ourselves, is when to stop doing active treatment. And one of the hardest things is to make the call, no longer for emergency department kind of admission. And when we used to work in the aged care facilities, there would be a time where we went, all right, there's 24-hour nurses here. There's doctors that can come in. There's specialized team that can come in. So let's no longer put them in ED, with the exception of if they have a fall and crack a head and need stitches or have a fracture or whatever. So end-of-life doulas are people that are trained in all of these things, all the things I'm talking to you about now. Now I would class myself as an end-of-life doula amongst all the other things I do. And what end-of-life doulas do is that they can walk from diagnosis, go through the planning, help with the assistance of all the practical stuff, and be there to talk to, help line up family as well. And one of the important things that we do is that through our interactions with everyone, we can kind of look ahead and go, that perception of that person's going to be problematic when we hit this stage. This person is really anti-morphine. That's going to be problematic when that's required. Or this person over here is against the syringe pump, or this person's against a hospital admission, and yet one might be possible, one might be needed. So we can massage things into place as we walk alongside people. Anyone can be an end of life doula. You know, if you're involved, you can definitely play that role. And the more educated we are, the more we're able to do that. And then, of course, there's other non-medical staff involved in the process of people who are dying, such as, you know, anything from massage therapists, physios, anything at all that contributes to comfort. I think that's about it for all the things that I wanted to say. Yeah, sorry, I hope I didn't go over.
You did not go over. That was great. Thank you very much, Satyam, for sharing your knowledge, your expertise, and really bringing home, I think, that we're learning from each other all the time. And this is the theme of this year's Dying to Know Day, is to empower communities to support one another. So there's lots of different ways that we're doing that. And I think we're doing it across our lifespan, is what I heard from you.
Yeah.
Thank you very much. So our next speaker today is Leith Maddock. Leith is a palliative care social worker as well, and also a bereavement counsellor for Silver Chain. Leith is also a celebrant. She's completed Death Walker training, which is the same kind of idea as an end-of-life doula training, and co-facilitates things like shroud making workshops. So Leith is going to talk about honouring life in your own way, personalising funerals and memorial services.
Thanks. And thanks, Satyam. That was a really great overview. It actually made me think of something that Stephen Jenkinson said, which is the way that we approach our death and the death of the people that we love is a gift to the future generations. And I think we really do show the way, and educating people really helps support people in that. So thanks. And it's great to join all of you today. I thought it was kind of fitting that I'm going to talk about funerals and I'm coming right at the end. So I'm basically going to cover different funeral options and also ways to make funerals sort of personally meaningful, as well as affordable and satisfying. So yeah, if you've got any questions, just type them in the chat box and Chandrika will moderate that later. I thought I'd start with just like what is a funeral? At the barest description, it's a ceremony that's held after someone has died, usually linked to the burial or cremation, but always linked in some way to the disposal of the body. But it's more than that. It's an opportunity to celebrate and honour the life of the person who's died. And it's also the formal end to the act of caring to that person and the start of mourning their loss. And in some faith contexts, today and in the past, the funeral was an important part of helping the deceased in their journey to the next life. These days, a lot of funerals are secular, and they are an important way in which the family and community begin to mend the tear in the social fabric that's been caused by a death, whether it was timely or untimely. And, you know, that importance has been recognised throughout history. In our society in the last 100 years, mostly because of advances in medicine and not being involved in so many wars, we're not so familiar with death. So we're less familiar with being involved in the funeral ritual and rites. And generally, it's outsourced to funeral parlours. And most people can go through almost their entire lives without personally encountering death. So there is no dress rehearsal. And that makes us unprepared for how to respond when we're required to deal with end-of-life matters. And in that, I'm including dying and grieving, but my brief today is funerals. And in most instances, people call the funeral director not long after the death, and they may perhaps see their person one more time made up in the coffin, and then they are gone. And that may be fine because everyone's needs are different. But it's good when we're choosing a pathway to know the options and not just operate in the absence of knowing those options. One thing that I always say at work to people who are dying and the people who are caring for them, when your person dies, the first thing that you should do is sit down next to them and take some time. Call your family, have a cup of tea, and just be in that moment with your person. Obviously, I work for Silver Chain, so obviously at that point you call the nurse, but if they have died at home and it is an expected death, it's a pretty straightforward process. If it's unexpected death, that is more complicated, and you know, sort of authorities have to be involved a little at that point, because someone has to certify the death. So just moving on a bit more to funerals, anyone can conduct a funeral. Marriage celebrants have to be authorised, but anyone can lead a funeral, and it's a privilege to do so if you're ever asked. And I would encourage you to never shy away from it, because it is a really important gift to the family if you can step into that space. A funeral is a milestone life event. So as a celebrant, it is your role to celebrate, to support the family to the best of your ability and pay full respect to the moment. Because on a really significant level, it marks the beginning of their life without that person in it. And acknowledging that can be relatively simple, but in other cases, such as a young person's death or death by suicide, it requires more thought and courage. And I think Satyam was talking about courage earlier too, how, you know, when someone is in palliative care nearing the end of their life, to hold your nerve and not call the ambulance. And likewise, when you're conducting a funeral, it is really important to be brave. I did some training with Zenith Virago, and she said something along the lines of that the role of a funeral is to spiral collectively in to touch the place where the grief lies, and then start to spiral out, bringing the mourners with you so they can symbolically leave that place and begin to reorient back to their own lives. And in our society, we can shy a little bit away from touching the places that hurt. But I think we probably all know that a funeral that doesn't acknowledge those places is strangely unsatisfying and doesn't do justice to people's sorrow. And for that reason, I do have a bit of resistance to the term celebration of life. In some circumstances, in a timely, well-lived death, it's perfect. But other funerals have such a big element of sorrow that it's important to think about the terminology that you use. It could be like honouring the life of, or a memorial service for, or anything. But sometimes I feel like we rush to the celebration of life because we don't want to touch the sore place. In terms of actual practical aspects of funerals, I always suggest that if people want to, that they dress and wash and dress their own person after death, because it's actually a really lovely thing to do. Sometimes, again, it might take a little bit of courage, and you don't have to do it perfectly, or you could just wash their hands and feet if you weren't comfortable washing all of them. But it is a really beautiful ritual that's been done throughout the ages, and I encourage people to take that up. We are living in very interesting times for the funeral industry, which is basically a big business dominated by multinational companies. Invocare own 120 funeral places in Australia. So White Lady, Simplicity, Oakwood, Pursley, Low Chipper. There's only a few locally owned ones in WA. These days, direct cremations are very common, and this has been quite challenging for the funeral parlours because it reduces their profit margin, basically. And lots of new players have been entering the field because it's been kind of easy. You don't need a big premises, etc. And that has made a lot of competition in the market. And most people do choose to either go with a funeral director, even if it is for direct cremation. But I think it's important to also know that you can apply for a single permit funeral license if you want to run the funeral of someone in your family or close to you, or, you know, if you're called upon it to do. It is quite a big job. I've done it a few times now. And there is a lot to organise around insurance, transport, storage of the body if you don't want to keep it at home, paperwork. So it's not a task to be taken on lightly, but it is very doable. And it is more affordable than a funeral, but probably there's not, for say a direct cremation, there's not a lot of price difference. It'd probably be no more than $1,000 or $2,000. So direct cremation is the cremation of a body with no mourners in attendance. You basically call them to come to your home or to the hospital, and they take the person away who has died, and you don't see them again. It is an unattended cremation. And the cost is usually $3,000 to $4,000. And that covers like moving the body from the place of death to the mortuary, later to the crematorium, the cremation fee, the certificate, and the holding of the ashes until collection. There's also the option of direct burial, but that is not common in Australia, but it's similar. The body is buried without mourners present. Traditional funerals, I think we all know about these, you know, $5,000 to $6,000 up to as much as you want to spend. There's no requirement for embalming or a whole lot of the other services that can be offered. Embalming is only necessary for above ground burials, such as a mausoleum or a crypt, or if the body's been moved across state or international borders. Funeral services, they can be, you know, it's important, an important ceremony, so it needs to have gravitas and ceremony. And for some people, the direct cremation method doesn't hold that for them. But it's really possible to have a memorial, you know, where people share stories and pay full respect to the person who has died after a direct cremation. And that can meet that need, as well as being a lot more affordable for families. And I am noticing at work that many families opt for direct cremation these days. With a traditional funeral, though, you do have the option of bringing the person's the coffin home for the night for a vigil, or there can be services at the funeral parlour with the coffin. So there are a lot more options, and for some people that is much more satisfying for them, and it fits in better with the way that they grieve and direct cremation. Green funerals, they're becoming increasingly popular, and there are more and more designated green burial sites. Cremation is still the option of choice for most people. Around 70% of people choose that. It's not very environmentally friendly, though. And in other countries, they're developing all sorts of ways for disposing of bodies through different kinds of cremation, but we don't have them here yet. And a green funeral is a burial in a designated natural burial site attached to a cemetery, because all bodies have to be buried in a cemetery, designated cemetery in Western Australia. In other states, there's a bit more flexibility, but not here. And the intention of a green funeral is to allow the body to return to the earth in the most environmentally friendly way possible. So only natural materials are used. The bodies are buried, but not as deep, to allow for microbial activity to help it break down and provide nutrients for the area in which local plants are usually planted. They're not really cheaper than regular funerals, but there is no need for an expensive coffin or a headstone or the ongoing environmental cost of lawn maintenance in a lawn cemetery, etc. So all of those things are worth thinking about. There's an option at Wellington Dam of burial of cremated ashes in a memorial forest, and they use microbes to neutralize the pH and sodium levels, and then can mix the ashes with the soil and a tree planted, because ashes are unsuitable for trees to grow directly in. So that's something to think about. Sometimes people donate their bodies to medical science, but in fact, they're not always accepted. So there always needs to be a plan B with a funeral director in mind who can collect the body if UWA decide that they can't have it. you need to apply beforehand to UWA so they know that the donation is in the pipeline. And before I close, I just wanted to mention funerals where the person who has died has no family or the family can't afford a funeral. There is a bereavement assistance program through the Department of Communities where there isn't enough money in the person's estate to pay for a funeral and family members can't pay for it either. But if family members have employment, they won't be eligible. There's a few other criteria around that, and only basic funeral services are funded, and cremation's not permitted unless it's specified in the will or culturally necessary. When a body is unclaimed, the body's held in the state mortuary for 3 months, then the Department of Justice organise a funeral. That's just kind of a bit of a brief introduction to funerals and funeral ceremonies. And yeah, thank you for listening.
Thank you so much, Leith. You've got a lovely way about you, and I get that feeling of reverence and the sacredness of the way that we can honour people when they've gone. It brought to mind a quote that I heard many years ago. It was at a concert with Ruby Hunter and Archie Roach, and they were explaining to the audience why all land is sacred. And they said it's because on every speck of dirt, a baby's been born and a person's died. And so I really can feel that sacred space that you're coming from. I have a quite practical question for you. So I've just checked the Q&A box and the chat box. There's no questions yet, but do put them in if you've got them because we've got a few minutes up our sleeves. My question for you, Leith, is I saw when I was looking at your bio that you facilitate shroud making workshops, and I wondered if you could tell us a bit more about what that entails.
They are a day with my friend Michelle. She's a textile artist, and I love sewing as well. And we spend a day with people that want to come and make a shroud, but also spend a day talking about death and dying and grief and caring for dying relatives. And we've run quite a few of them now, and they're always incredibly rich. And the shrouds that people make are also incredibly, they can be really sort of complicated and beautiful, or they can be very simple. And a shroud can be used in a coffin. In Western Australia, you always have to be buried in a coffin. So, but they are just a lovely ritual to undertake as part of the grieving process. Like, I know that people like to give everything they can to the person that they love, and a shroud is a really nice way to do it.
Beautiful, thank you. So again, I'm not seeing anything popping in, but I'm sure you've got lots of thoughts if you've been listening to all of our wonderful speakers. So let me recap what we've done and also tell you what comes next. So we've heard from Julie Verley from Solaris Cancer Care. We've heard from Claire Doyle, Palliative Care Nurse Practitioner. We've heard from Shelly Skinner, CEO and founder of Lionheart Camp for Kids. We've heard from Satyam Brown, accredited mental health social worker from Surya Health. And we've just heard from Leith Maddock, palliative care social worker and bereavement counsellor. So we're so grateful for all of you sharing your knowledge and your insights with us. You've been very generous with your time. I also want to thank the organisations behind today's event. So although you might see the Breast Cancer Care WA branding, this has been a Cancer Wellness Centre community event, a collaborative project with Melanoma Institute Australia. Their WA office is here on this site at Cottesloe, as well as Solaris Cancer Care and Breast Cancer Care WA, working together to really kind of represent this theme of community support. We offer it to people with all kinds of cancer on this site, from the time of diagnosis through recovery and survivorship, and we walk alongside people for as long as you need and want us, including through these phases at the end of life and beyond with bereavement support programs. So what happens next is that we're going to break for some refreshments for the people that are here on site. And if you're listening from home or somewhere else, of course, you might want to take a break, have a bit of movement, maybe shake it off, have a dance, go look at the trees, let yourself feel whatever you're feeling. And then we will send out a link to everyone that registered. So if you got the link for the webinar, you'll get the link for the online discussion group. Before I close this meeting, it'd be great if you just want to pop into the chat or the Q&A box if you intend to join that. That's going to start at 1 o'clock. So you've got an hour or so to, do what you need to do. If you can just let us know your intention, that'd be great so we can estimate numbers. And we'll send out that link shortly so that you can hop online and join an online discussion from 1. That'll be facilitated by Holly Pertwee, one of the counsellors here. And if you're on site at the Cancer Wellness Centre, you can enjoy some lunch and a facilitated discussion group in person. This recording will go up on the Breast Cancer Care website sometime in coming days, maybe give us a week or something like that. And it will be a resource that you can come back to. We'll also send out to you those links to the websites of our speakers so that you can contact them directly if you have further questions, reflections, or need their services. So thank you all again, speakers and participants, for your attention and your time and energy that you've given to this. We really appreciate it, and we hope you have a beautiful rest of your day.